So we are very thankful that Dr. Ference-Belhomme is presenting this morning. She completed her doctoral training in clinical psychology at the University of Calgary in 2016, followed by her residency at the Alberta Children's Hospital. Throughout her training, her primary clinical focus has been with children and adolescents, particularly those diagnosed with neurodevelopmental disorders. She is now a registered psychologist in Alberta and has been working in the neurosciences and sleep clinics at the Alberta Children's Hospital since 2017, while also offering support to the Pediatric Movement Disorders and Tourette's Clinic. Her clinical work has evolved over time to include providing CBT to patients diagnosed with tic disorders, as well as psychotherapy for those also struggling with adjusting to the day-to-day stresses tic symptoms can produce. I hand it over to you, Dr. Ference-Belhomme. Thank you.
Thank you, Julian. Can you hear me okay on this?
You just need to be a bit louder, a little louder.
Let's see. How's that?
That's a little bit muted. Is it?
So I think this is probably, let's see.
It seems like others can hear well, so maybe it's just me. You're fine. It's okay. It's just me.
Perfect. All right. Okay, so I'm going to go about sharing my screen then, and we can get started. And here we go. Might hear my children screaming in the background. Okay, here we go. Okay, so thanks very much, Julian, for the introduction. I've got a lot of content to cover today, so I'm going to be trying to get through this within about 50 to 55 minutes. I think for questions, please use the chat box. That would be great, but I probably won't get to the questions until the end, just for the sake of time and making sure we end within the hour. Okay, yes, so we'll be talking about cognitive restructuring, self-esteem, and coping and social interactions for individuals with tic disorders. So for this topic, I'm going to be covering a fairly large section of cognitive restructuring. That should be very familiar to those who use cognitive behavioral therapy regularly. But within there, there's going to be information more specific to those with tic disorders and how to apply those appropriately. Self-esteem issues are super common for many individuals. Let's be real, right, in therapy. But there are particular considerations for this population as well, which I'm going to review. And then lastly, we'll discuss some social life challenges that are unique to this population. And you'll just notice too, for the purposes of this presentation, I'm using the acronym TD to represent tic disorders overall. And I just want to note that the vast majority of the academic content that I'm covering here comes from this particular guide, this manual. I strongly recommend it to anyone who is working with individuals in this population, youth, children, or adults. It could be very helpful. Okay, so we put together this presentation because tics are often not the only issue that children and youth with these disorders come to the table with. There's often complex challenges in social dynamics that tics can sort of breed, which can then also negatively impact the tics themselves and then contribute to other problems, creating this sort of vicious cycle. In my practice, most parents and children come in with different priorities for treatment. That's probably often the case for any disorder, really. For the population struggling with tic disorders, the priorities often take the form of parents being quite concerned about the tics themselves. They worry about peer issues for sure, and they're often worrying that if their child does not control their tics, they will be made fun of and experience more problems as a consequence. So there's certainly some parents too that are more bothered by the tics themselves as well and might get quite annoyed with them. In contrast, though, the youths that I've seen tend to be much less bothered by the tics. And if they do present with concerns about things going on in their lives, it really tends to be more focused on friends, peers, school, and if they have siblings, sibling relationship challenges or relationship challenges with their parents as well. So these concerns for youth tend to be quite typical of a broader population you'd be seeing. So as a clinician too, you will have your own priorities, and I have a whole host of things written out here. So you might be thinking about if this child could improve with tic management, that would be great. They might also need work on mood, anxiety, behaviors, issues at home, so on and so on, communication problems. Maybe psychoeducation is needed, medication consultation, and whatnot. But just like doing any therapy with any child, you really have to make some clear choices about where to focus. And you're often not able to fix everything, right? That's the reality of it. So using your clinical judgment about where to start is really, really crucial. The spotlight phenomenon is a cognitive bias that's talked about in different contexts in psychology. Here we think of our patients as having specific areas in their lives that they're most worried about, and have a sort of attentional spotlight on those things. Parents will have different things too. And for us as therapists, we need to try hard to see the whole picture, right? While also respecting and trying to focus more on what the child or the youth's priorities are. This is because if we dive too far outside of the child's spotlight and what they think is important, we're going to quickly lose them in therapy and won't really get anywhere. So it's a delicate balance, but you want to try to attend to what the child or the youth is needing while also considering some of the background information and noise. So now I'm going to move on to a bit of the assessment approaches for how to sort out these areas of concern for both the youth and parents, and then move on to some treatment discussion. Okay, so when you're doing an assessment for youth with tic disorders, and the assessment is focused on what you're going to be targeting in psychotherapy, you want to complete your usual intake interview like you would for any other youth presenting with a mental health or adjustment concerns. But within each area of functioning, you want to start to think about and attend to how the tics are getting in the way or not. So for example, what are your tics like at school? Or how do they get in the way of your social life? Telling about the peers at your school, how do they treat you when you're ticking, and so on. Often I've found that youth don't spend a lot of time thinking about their tics in this way. And instead they tend to think more about how the tics are playing a role in their lives. Or when they do start to pay attention to it more, in their lives, when you're talking with them, it can be really useful in therapy moving forward, and it can create some additional insight for them. Many parents too, so the parents will often be starting to assume that the tics are causing more problems for their child than they actually are, or that the child even endorses, or that the child is even aware of, probably due to that spotlight effect. You want to be gauging too how bothered the youth is by their tics and what it is that bothers them the most. So this helps to gauge interest in therapy and in addressing those concerns. So using a scale of 1 to 10, where 10 is the absolute worst, how much do your tics bother you on average? That can be a way of just gauging kind of how important something is to the child. And something that's interesting too, if you've used this with the child and with the parent, might often find a difference in where they're rating things too. So that can be really informative. I think while these questions are helpful to sort out motivation for CBIT, as you may have heard on the previous presentation on CBIT, they can also serve as important information for psychotherapy when you're not even doing CBIT and you're focusing more on some of the other concerns in the child's life. And then also to getting the child to rate their list of priorities too in therapy can be very helpful. So for example, asking them, what would you like to talk about in sessions, and get some help with, what do you think your parents would like to happen as well? So I would start with those for sure. There's some supplemental assessment tools too. Probably many of you would be familiar with some of these. Some of these test tools are available for free, others are for purchase. Some of the skills that I like to use for looking at mood and anxiety concerns would be the SCARED, or the Screen for Child Anxiety and Related Disorders. There's a parent and a child form. Children's Depression Inventory, and that's for when you have like the younger age group. For the older age group, I really like the Big Youth Inventories. They cover quite a lot of issues. and the multidimensional anxiety scale for children. That can also be quite helpful. Behavior issues, you can use a BASC, the behavior assessment scale for children. Those can be really great. Now, for each of those 3 or 4 forms I just talked about, there are teacher forms for these as well. And it's kind of like a clinical judgment, whether you want to use a teacher form or not. Really depends on if you're working closely with the school or if you'd be working closely with the teacher. So it's kind of like your call. But sometimes simply just talking to the teacher over the phone can be sufficient for your work with the youth. Often I don't end up talking to teachers just for simplicity and because I don't often find that it's very helpful. Kind of just depends. And then lastly, for self-esteem concerns, there is a free self-perceptions profile available online that can actually be quite useful for working with this population. So I definitely take a look at that. Okay, so many of the youth that I see with tic disorders or not struggle with some level of self-esteem. So we're going to be reviewing more of the self-esteem treatments later on in detail. And if self-esteem is a main concern that the family is presenting with, having a more detailed assessment of those concerns will be helpful for gearing your treatment. One way to think about the construct of self-esteem is to divide it into global versus domain specific. So where global self-esteem is how good an individual feels about themselves overall. So with tics, some kids will feel completely low on themselves because the tics just sort of overshadow so many aspects of their lives that it becomes hard to see themselves as separate from the tics. And so that can be very, very challenging. Most youth and children will, however, feel good about themselves in at least 1 or 2 domains, and less badly about themselves in some others versus others, pardon me. And if they're more or less bothered by tics when engaging in certain activities, this would be important to know and to talk about as well if you're going to be providing treatment for those concerns. So I've got some examples of different domains on here. I mean, the main ones, the academic domains, social domain, and physical. So asking some really specific questions within these areas can give you good information about how tics are impacting them at school, how they feel about themselves when they're ticking there. For the older teens too, you might want to ask them about dating and some of their closer friendships, how tics kind of get in the way or don't in those contexts. And that can be really informative. Okay, so once you've completed your assessment, it's really important to be transparent with the youth and the caregivers. So you want to share your overall impressions with the caregivers and the youth as appropriate to their developmental level, and review the different options together. Treatment recommendations, like I kind of touched on before, is they should be, I think, more focused on the youth's current priorities if you're working directly with the child, right? So you want to be able to gain some motivation, some trust and interest in the treatment process with them, and really what matters most to them, because it's their life at the end of the day that they're living through. That said, you also want to make sure that it's like clinically relevant too, and going to probably be helpful for them. You want to consider the timing in the child's life too, and the appropriateness of intervening now. So if you find that the youth is just not motivated to do this kind of work, just similar with CBIT, if they're not motivated, it's not going to work. It's the same thing with this stuff as well. So treatment's going to be quite challenging for someone who's just not into it, right? That they just don't want to do it. So in that case, you may want to focus more on working with the parents, giving them some psychoeducation, working on some parenting strategies, communication strategies, that sort of thing might be more helpful. And you also too, you want to be flexible and encourage the youth and the family to be flexible during the whole treatment process. So making sure that you're really discussing about, and being realistic. We're not here to fix everything. Life is a long journey, and there's going to be lots of things over time that will need adjustment and tweaking. And so what we can do with our time together would be to help change the path perhaps that a child is on, make life a little bit easier, give them some extra tools in their toolbox to work through some of those hardships and challenges that are a very normal part of life. And to some extent, I think setting them up with this idea of like, rather than seeing any kind of challenges or difficulties as this ginormous hurdle to overcome, see it as a challenge, as a way of sort of building oneself and becoming a stronger person overall. So some of that mindset shift can be really helpful, just sort of long-term moving forward with them too. Okay, so moving on to the cognitive model and how that interplays with the tic disorder population. I really like how Aspeel and Houghton, 2018, how they describe the cognitive model in terms of helpful patterns of thinking that can emerge in youth with tic disorders. It's sort of, they describe the process as sort of working like a chain reaction of how unhelpful thoughts and behaviors can really have long-term cascading effects within this population. So essentially what they're hypothesizing here is that in the beginning, for most kids, tics are barely noticeable, often eye blinks, small nose movements. You know, they could be very young when this is happening, like 6 years old or younger even. And most parents will be like, well, what are you doing? Or, you know, stop doing that. Or, you know, is there something wrong with your eyes? Let's go to the eye doctor, whatever. It very, very like normal stuff that parents might do, or other or teachers might observe. Nothing necessarily terrible, but it's very small, right? You're noticing them. Other people are noticing the child's tics. And in time, inadvertently negative comments or reactions from other people kind of build up. So if a child, you know, 6 years old, they make a bit of a grunting sound, another kid might say like, why are you making that sound? Or maybe a sibling might get annoyed, like, stop doing that, right? So it's very, very subtle. But then as the child grows and gets older, they become more aware of the tics themselves, and they can then subsequently become embarrassed because others are noticing them too. They might begin to anticipate negative reactions when they're feeling the urge to tic, or when they do tic, or both. And then to prevent the negative reactions from other people and from feeling uncomfortable themselves emotionally, they may try to suppress the tics. And we already know that that leads to a lot of frustration and discomfort, right? So getting really frustrated with themselves by this point. And then through this process of suppressing the tics, it obviously becomes very difficult, painful for a lot of individuals, very frustrating. This of course naturally would lead to increased negative affect and a child's tendency to want to avoid others and avoid activities, because when I'm out around other people and they notice my tics, then I have to hold them in, and then I feel uncomfortable, right? It becomes like this very vicious cycle, and avoidance becomes very rewarding. So in that moment. But long term, of course, avoidance leads to a decrease in valued life activities. It leads to a decrease in opportunity for positive interactions. And of course, less practice building social skills during really important developmental periods. So it can be quite a big problem. And I think this theoretical model fits well with much of what I've seen clinically too. And but at the same time, it's important to know that the research specifically on tic disorders and cognitive restructuring, it's still emerging. But there is support in the literature to use CBT in this particular context. Okay, so through these early experiences and the internal as well as external feedback loops that are going on constantly, it's not hard to imagine that a youth will often end up associating their tics with embarrassment, with inconvenience, with pain, and causing an overall disruption in their lives. It could lead them to an overall belief that the tics are all bad, which then lends itself to certain unhelpful thoughts. So really, like, it's them starting to think like, I can't do certain activities, it can't fit in, there's something wrong with me, I'm a weirdo. Really common unhelpful lines of thinking that could come out of that process. So Cognitive models propose that this long-term pattern of unhelpful thinking ends up impairing a person's ability to function across multiple domains in life, unsurprisingly, and ultimately decrease quality of life. Cognitive behavioral therapy is often really useful in situations like this, and it can be successfully applied to the tic disorder population. So I'm going to review some of the thinking errors that are common to youth with tic disorders in this model, and I believe that probably a lot of people who are watching this have experience and training in CBT. So I'm not going to do a whole lot of like the basics of covering CBT. You can probably get that information elsewhere if you need it. So as a clinician that's working through CBT, we end up introducing thinking errors as a part of helping our patients become increasingly aware of their unhelpful thinking patterns and their tendencies to think in ways that inevitably lead to negative feelings. These are some examples of common thinking errors that pretty well every human being engages in at some point in life, right? And often on a regular basis. None of us are immune to these things. The examples on here on this particular slide are specific to the tic disorder population. So for example, jumping to conclusions, this is when we're greatly inflating the likelihood of a negative outcome. So if I tic in class, then others will laugh at me. Or a fortune telling, so my tics will never get any better. I'll never make friends because of my tics, and so on. So you can imagine how living with tics could cycle a child into really believing many of these different examples and potentially even rely on these really fairly automatically and believe them as truth without really taking the time to challenge them or reframe them to be more helpful. Often the thoughts are so automatic because they've been reinforced so many times over the years, just like in that cycle I was describing on the previous slide. And so really getting the child to become aware of those is super important to then move forward and start to challenge them. Okay, so CBT has been shown to be effective for reducing negative impact of symptoms in a wide variety of conditions, ranging from various mental health issues like anxiety, depression, and even schizophrenia, to chronic pain experiences across age groups, children, adolescents, adults. And the research in this area for the population with tic disorders is emerging and really promising. So the general goals of CBT in this context would be to try to develop a more positive view of the self, okay? Really encouraging re-engagement in life. So like I mentioned before, a lot of these kids will start to avoid social activities, academics, extracurriculars. And so getting them to re-engage in that while also teaching them how to better manage the stress, anxiety, that tends to worsen with tics overall, which then in turn can increase stress, right? It's very much a bidirectional relationship between the two. So often CBT will describe unhelpful thoughts as being negative or dysfunctional versus positive or realistic. But I've been using the unhelpful versus helpful term throughout, and I really prefer that way of discussing thoughts and thinking errors in particular, because especially in this population, there's times when negative thoughts are kind of true. And in a few situations in therapy, we can also label negative thoughts as, in few situations, sorry, we can label negative thoughts as helpful. So I like this distinction better as having it be unhelpful versus helpful. And this can be really validating, I've found, with kids, because so many have been told, like, oh, just think on the bright side. You know, oh yeah, you got tics, but you know what? You're really smart. Think on the bright side, or some variation of that. And that kind of can inadvertently invalidate the child's feelings about the tics, right? So, right. So let's just go through an example with the general cognitive model. In a particular situation I've got here, we'll say there is a child named Ben. He's in the 5th grade, sitting at his desk in class. He lets out a vocal tic like a squeal sound. And his classmate Holly looks up at him briefly before looking back down at her work on her desk. As a therapist, you want to go through how you would ideally like to break this down. Bearing in mind, of course, the youth will likely need coaching to identify all of these pieces at first. After a couple sessions, they should be quite able to identify each part. So we have our thoughts, we have our feelings. I add in body reactions because I think particularly in this population, it's, tics would be the body reactions. And then you have our behavior. So the situational trigger, the example that I just talked about, we'll say Ben has the thoughts like, she thinks I'm such a weirdo, no wonder I don't have friends. That can lead to feelings of feeling anxious, sad, hopeless, and so on. Increased tics or urges to tic, plus the physiological symptoms that come with anxiety. So increased heart rate, sweating, muscle tension, and so on. And then the behavior, turn away, lose focus in class, avoid interacting with Holly, avoiding talking to others, faking an illness just to get out of things, right? So a lot of avoidance behavior out of this particular cycle, which then, of course, perpetuates the cycle itself, and it goes back and forth. So, sorry, just one more piece here. So now that you have this vicious circle, and what you want to do is teach the youth how to challenge their thinking so that you can then see changes throughout the model, and moving on to more helpful feelings and behaviors after that. So for how you would actually go about working with the youth on restructuring their thoughts and challenging them in the moment, first you need to really ensure that they understand the concepts and are starting to become aware of their thoughts. So reviewing the cognitive model with them in session is important. Getting them to track their automatic thoughts regularly and become more aware of them in different situations is going to make the actual restructuring easier as time goes on. And you're going to get better buy-in. How you approach CBT for different age groups, it really needs to be sensitive to the child's age and developmental level. Sometimes using activities like games and whatnot can really help and make the concepts more engaging, plus individualizing them as well. So for when you're beginning to introduce thinking errors, starting with ones that you notice occurring within session. So when the child is just talking about their everyday, that can be a time for you to kind of cue in, oh, is this a fortune telling thinking error? Is this personalization or whatever, right? So keep track of them in the back of your mind and making a careful decision about when you actually bring it up and sessions start to challenge them. Takes some careful timing, and of course you don't want to do it necessarily right away because you can bring up a lot of defensiveness. So for example, when you're looking at starting to challenge unhelpful patterns in thinking and thinking errors, one of the techniques you might use is Socratic questioning, which is basically just that process of questioning that really stimulates a curiosity and inquisitiveness on your end to help the child start to gradually reveal unhelpful thoughts and patterns and behaviors. So an example of a Socratic question might be like, well, what is the evidence for this thought? Is there an alternative explanation? Or what is the worst that can happen? Some of these can feel a bit confrontational for some kids who are quite sensitive and attached to these unhelpful ways of thinking, which makes sense because if they've been thinking in a certain way for so long that, my tics make me look like such a weirdo, for example, that particular unhelpful thought can be very tied into a core belief. And so when we start to challenge it, we have to be very careful about the when and the how, so as not to build up the defensiveness and the protection of that particular thought, right? So maybe using some other techniques or just kind of like tabling it until you can get there and work towards those core beliefs would be more helpful. The downward arrow technique, that involves just guiding the patient to follow their worry through to the end, essentially. So often a worry will start with something like, they'll make fun of my tics. And then you can ask them, well, when will that happen? And then what would happen? They might say, well, that'd be embarrassing. Okay, that would suck, but then what would happen? Well, no one will want to hang out with me. Okay, well, then what? and then, well, I'll be alone forever, right? And so basically the idea is that you're working towards getting to a core belief at the end, which is really what is feeding the surface level worries that a child may have. And I like to think of the core beliefs as like the root to a tree of worry, essentially. And so working with the child to start to identify those can be very helpful. So during questioning, I kind of talked about this already, but you really want to try to get the child to realize the errors of thinking on their own. So being thoughtful in how you're asking the questions and where you're kind of helping them to discover more about themselves. So you might be able to see what's going on right away on the surface, right, as the therapist. But for the child, it's going to take some time for them to start to really see how these things are not helping them. I do find with youth, with young kids too, especially involving the parents is very helpful. Keeping them in the loop minimally about what their child is learning and any ways that they can support that learning at home. Teaching them different strategies for how to best respond to their child when their child's feeling distressed or worried. So some ideas would be like coaching the parents on how to engage in reflective listening. How to appropriately validate and normalize a child's thoughts and feelings. And really importantly, having the parents understand that we want to avoid jumping to problem-solving strategies at the outset. That one is really tough for parents. I'm a parent too, and I find that's really tough to not jump into problem solving. When kids are really young, you kind of do that a lot more. And as they get older, you really don't want to be doing that because it's going to be more invalidating and frustrating for them. And coaching the parents too with asking questions that encourage their child to reflect on what's happening more. And kind of you're building up independence for them and self-efficacy and being able to solve their own problems. So again, I think it's very important to involve parents regardless of the age of the child. Okay, so thought record examples. I think probably most people here watching this have some experience with using these. I've just got some examples of different ones I use. Obviously, homework is really important for CBT to be effective. The research really supports that improvements are faster and better long-term when kids will do them. There are various strategies for getting compliance for doing these too. So I'll kind of leave that to you to sort out because that's talked about a lot in other literature. The types of thought records that you want to use, just attending to developmental level really. So this one up here is quite detailed. And it's probably one that I would use much later on in therapy once I've already spent a good amount of time understanding the thoughts, understanding feelings, body reactions, rating emotions, and what was done to manage the emotions. Those are all really important things. But again, I wouldn't use these right at the start of therapy. It'd be much later on down the road. You could do something very simple, like just talking about, getting the child to identify a situation or trigger, what worried thoughts they had, and then just having a bit more realistic thoughts, more helpful thoughts on the other side. That might be one to use. Another, it's a little bit more basic, but has a bit more to it with identifying intensity of emotions. And then for really young kids, having some visual cues can be really helpful too. So I'm going to go through a case example. So part of my reading between the two people as we go through, I know you all can read, but I don't want to just sit here and have imagine that you're reading it. So this is a case example that I think does a very good job demonstrating how you might go about a conversation with a youth who's presenting with a clear thinking error. So for this case, the clinician has already had the youth complete thought records and is beginning to move towards teaching cognitive restructuring. Okay, so as a clinician, over the past week, I had you monitor your thoughts and write down the most stressful ones on your thought record. How did it go? Oh, it was okay. I did it a couple times. It was hard at first, but got a bit easier. Great, glad you gave it a try. What did you learn? Okay, I have a lot of these thoughts. So when I was at basketball, I kept ticking on the bench, which was really distracting me from the game. I wrote down that I had the thought, why can't I be like normal people? I don't fit in at all. So the clinician very very greatly, very wonderfully picks up on the, what do you mean by normal people? So that's going to be the really unhelpful thought here. Okay, so I mean like people who don't have tics. Clinician validates that, but then starts to challenge. Okay, so yeah, that's something that a lot of people with tics deal with over their lives. You're right that in some ways, some tics do make it harder for you to do things. Okay, so very validating and normalizing. What are you feeling when you're thinking that? Terrible, kind of sad, angry, or anxious. Okay, yeah, that makes sense. You know, specific body reactions, right? So the clinician is starting to work through that CBT cycle. Yeah, I feel nauseous. I had a headache starting. Felt like the tics were just out of control. Wasn't even tired from playing basketball. The game had really only just started when this happened, and I was barely on the court. Clinician says, again, validates this. Yep, that makes sense. Totally normal. Remember the discussions that we've had about the connections between mind and body. So when we feel anxious about something, certain sensations come up. And in a way, these body reactions could also be a warning sign that some unhelpful thoughts are taking a lot of airtime in your mind. That's really the key, because most people, and youth in particular, are very aware of the body reactions and what's happening inside of them, but not as aware of their thoughts, right? So we really want to try to help them get a much better sense of that. So he says, yeah, that makes sense. I tried not to think about the tics or the fact that I feel like such a weirdo. Was it helpful? Nope. And the idea is like, well, because if you're trying not to think about something, then it becomes a lot harder. So helping now, the clinician is helping the child work through identifying a more helpful thought. So the youth might say like, okay, maybe I actually do fit in. And so the clinician says, yeah, okay, that sounds good, but what evidence do you have? Because we want to make sure that the child actually believes this, and it's something that's a bit more believable. It's not just the opposite of the unhelpful thought they were having. Okay, so identifying more evidence for it. The child says, so there's some kids that ignore me, but I don't really like them anyways. Okay, right. No one is liked by everyone. Sounds like it wouldn't really improve your life to be liked by them anyway, since you're not a big fan of them either. Yeah, so that can be actually too very helpful and validating just to have out in the open like that. Okay, so thinking about the fact that you have friends, you get along well with your basketball team and coach, as well as your school teachers and some classmates, it makes it hard for me to believe that you actually don't fit in, even though you have tics. Okay, so, and then they just kind of like wrap it up very nicely to kind of talk about how like, yeah, this is how, this is how automatic thoughts work. And yeah, leave the youth on. Okay, give it a try. So remember the example that we went through before with Ben, who was in the 5th grade. He's sitting at his desk, let out a vocal tic, and Holly kind of looked up at him briefly, then looked down at her work. So after going through all of the questioning and whatnot, like in the previous example, you might be able to get Ben to start to think more about helpful thoughts in this situation, or ones that are a bit more accurate. So perhaps she just looked up because she heard a sound. Everyone makes sounds sometimes. Okay, that's much more neutral, calm, might make the child feel more confident. Body reaction, well, nothing really changes. Nothing changes to the tics, stable body habitus, really. And then the behavior, staying focused, talking to Holly as usual, go to class the next day, not avoiding. That's really the ticket, right? You don't want them to be avoiding everything. So just some troubleshooting. Negative worldviews, remember, they can be accurate. So it may be very true that the child is having challenges at school, having challenges at home, might be struggling with friends due to a lack in social skills. You don't want to challenge these, right? Like you want to be able to acknowledge them, validate them, normalize them, problem solve, right? So finding alternative, socially rewarding environments could be very helpful, like seeing about the child getting involved in different sports, extracurriculars, clubs, working more with the family and the school where possible. Another problem we might come into insight. So insight can be here or there or a little bit in between. Really thinking about the developmental level of the child you're working with. Consider the timing of the intervention. They might want to delay it till they get a little bit older, more mature. And remember that comorbidities could be starting to emerge as well. We know learning disorders, ADHD, those are common for individuals with tic disorders. So you may want to be thinking about breaking down the concepts into smaller bits, spending more time on each, use some in vivo exposures and role plays. That can be very, very helpful. Discussing negative feelings and thoughts is hard. It can be very uncomfortable. And so sometimes you even just have to spend some time focusing on the discomfort a child might be having, just talking about this stuff in general, right? Before you can even dig into the meat of the problems that they're facing in the outside world. They might just be having a hard time talking about the negative stuff within the therapy itself. So focusing on that can be helpful to kind of move forward. And maybe also too, another strategy could be to use examples of situations that are not related to the patient's particular life or issues. Actual versus perceived limitations of tics. So some tics absolutely are physically limiting and interfere with physical tasks. Vocal tics can be quite disrupting as well and cause a lot of embarrassment. But sometimes the actual disruption of the tics can be less than what the perceived disruption is. So sometimes you'll have to work around that with the child as well. Okay, so moving on to self-esteem. So when it comes to managing self-esteem, something you should immediately notice is that many youth experience clear cognitive distortions or unhelpful lines of thinking about themselves. So again, based on cognitive models, this is from a process of negative feedback loops, really from internal and external cues. The treatment for low self-esteem involves a degree of cognitive restructuring work, of course, but with additional opportunities to re-engage in life and refrain from avoiding potentially negative situations, because if you're avoiding potentially negative situations, you're also losing out on positive ones too. So I found that negative self-evaluations can be very tightly held by youth, and it can feel quite personal to start to really address these in therapy. So this I think is because it's very much tied to core beliefs. And so really understanding those concepts in CBT and how to address core beliefs as a clinician is really important. For the purpose of this slide, I have different ways of teasing out cognitive mechanisms of low self-esteem. So one would be unrealistic self-standards. So what this is dysfunctional attitudes that involve an unattainable expectation for the self. These are like rigid beliefs about performance or, tendency to be perfectionistic, and rigid beliefs about social acceptance. Okay, so for example, if I show any tics, I am a complete failure. I cannot tic if I want to be accepted by others. Forgetting to use my competing response today is just as bad as not using it at all. Okay, so we're wanting to address those. Inaccurate self-evaluations. So what this is referring to is youth can inaccurately judge their true abilities and see them as much more negative or impossible to achieve. Okay, so I can't play basketball because of my tics. I can never have a relationship with someone because of my tics. I'll never be able to manage my tics. So recognizing those when they come up. The undifferentiated self-structure. So this has a little bit more to it. I think it's very, very helpful. So let's see if I can try to explain it well. So this is really reflective of how complex the self is. So the number of and distinction between different aspects of the self. Okay, so really thinking about that for a second. Many people have different levels of self-esteem in different areas. So some kids will feel, I kind of touched on this before, that like some kids will feel much more confident in their sports abilities than in their academic abilities. But for people with few aspects of self and limited differentiation, then any positive or negative feedback is going to be felt much more or less globally. So for a child without extracurriculars or limited social life, if they receive some negative feedback about their school performance, they might be more likely to have a lower self-esteem overall. Okay, so if a youth identifies with few aspects of self-definition, they're more likely to feel a functional impairment of the tics in all domains, okay, which is going to negatively impact self-esteem. So I think this is a very important piece to consider and to think about, as you're working with the child. The inauthentic or false self. So what this refers to is a suppression or hiding of one's true thoughts, feelings, and behaviors. This avoidance could stem from hopelessness about pleasing others, and it's really embedded in a sociocultural context. So there can be a lot of stigma from tic disorders. And so a child may be wanting to hide their tics more or their diagnosis in general. And it really varies, I think, from one child to the next, how much that plays a role. So as far as treatment goes, so this looks like a small slide, but it's pretty content heavy. So when you're targeting self-esteem in treatment, one of the you have to remember too that it's not necessarily realistic or possible to help someone come to a fully balanced self-esteem for the rest of their life after having this these wonderful sessions of therapy with you, right? Like self-esteem fluctuates over time as kids get older, but really, when they're really young, you can plant some seeds that hopefully will grow into a more positive direction. So you can make some progress in some domains. But I think also too being realistic about the scope and talking with the kids too about that reality as well, so that they don't start to feel like bad about themselves again when things aren't looking as rosy and perfect about themselves. So one way to start with targeting self-esteem, psychoeducation, just normalizing and reducing the stigma tips can really go a long way for a lot of people. In Dr. Prinshap's lecture, she talked a lot about psychoeducation, and really even just providing that information can really, really just help a lot. Sharing experiences too. So this can be done in a variety of ways. There's a number of excellent resources online nowadays with videos of youth who talk about their experiences of having a tic disorder. There's some celebrities too that have self-disclosed, including Billie Eilish, for example, who's quite popular with teens these days. And really the point of sharing experiences for kids is for youth to see that, one, they're not alone, and two, that other people who have tics can also be successful and live meaningful lives. So there's also a video online. It's called I Have Tourette's, but Tourette's Doesn't Have Me. That's quite a good video too. Related to this is advocacy. So for some youth, they might be so inclined to participate in some kind of advocacy work to reduce the stigma related to a tic disorder. That can help improve self-esteem, of course, and self-advocacy. Tourette's Canada is a really great resource for this, and finding a lot of nationwide activities that families can get involved in, including different fundraisers and awareness campaigns and so on. On a smaller scale, I do find that the more comfortable a youth is in telling others who ask about their tics, talking about their Tourette's to other people, if you can get your patient to be comfortable talking about their tics, that's going to go such a long way in helping them accept themselves and build up on their self-esteem. Cognitive restructuring. Okay, so we talked a lot about this. Really attending to those things in therapy, noticing and talking about positive beliefs youth might have about themselves is also really important. As clinicians, we tend to focus on the negative and the things that aren't going as well, but making sure that you're attending to the things that the child is talking positively about and does have going on in their lives that is really beneficial and positive. Right, so there's some fun activities too that you can try in therapy to encourage building up positive self-schemas. Many of them can be or have been adopted from the positive psychology movement. So even just looking into that particular area, getting the child to journal, identify good things about their day, and so on. Assertiveness training. Okay, this is a very important one for targeting self-esteem. Reviewing different communication styles with youth can be really helpful, but I often find you get more out of this by engaging them into some role plays and assigning homework. I think also to talking with parents and getting them really on board with understanding that this is happening, that they are doing this. this kind of work can be really helpful, because sometimes practicing to be assertive can come off as being aggressive. And so you want to make sure the parents are involved in practicing with this as well. So just in the interest in time, I'm going to go through this a little bit more quickly because we started a few minutes later. For troubleshooting some of the self-esteem intervention, I think it's important for families to understand that even with perfect following of CBT and the best medication management, there's no cure or with treatment for tics, right? So making sure that everybody really understands this is potentially more of a lifelong thing to be dealing with. And if you're finding challenges with sticky thoughts that are quite focused on distress around having a tic disorder, you may find moving into a more acceptance-based therapy approach to be more helpful. For some youth, beliefs about themselves are quite rigid and difficult to challenge. And you might want to focus then on moving towards a motivational interviewing approach to really gauge whether doing any work in this area is an issue of motivation to change, developmental timing perhaps, or a bit of both. Within the family too, some parents might be more distressed by the potential impact of tics than are the children themselves. And so I've met some parents that are quite irritated by the tics that their children are showing. And you might notice that as you're working with them, that maybe you got to do a bit more work with the parents to ensure that they're actually following some of the recommendations of essentially ignoring the tics. Because sometimes that's a lot easier said than done, right? It can be quite tough for some parents, and that can also play a big role in perpetuating some self-esteem issues. So we know that for children and youth with tic disorders, that bullying and discrimination and social problems are quite common. Okay, so I don't want to spend too much time here, again, in the interest of time, but really, I think that this highlights the need for helping children to kind of get themselves out there a bit more, avoiding, getting them to be in better and getting them to be in some environments that are going to be much more helpful for them in terms of building friendships, long-lasting friendships, and having more positive peer interactions as much as possible, because friendships really do offer protection for later problems. So doing what you can to ensure that kids can have this opportunity. There's a variety of interventions for this. I think as a clinician, when you're doing individual therapy, this can be really tough. A lot of this work ends up being done in schools. So involving yourself, if you can, within talking with teachers or looking at ways that the child can promote more tic acceptance at a greater level. Sometimes, the discussion of having presentations about Tourette's or tic disorders at school can be really, really important and powerful. But again, you have to really kind of like see where your kid is at, where your patient is at, as far as what's going to be easier for them or not. Thinking about developmental considerations is, of course, really important here too. I think, again, I want to highlight the idea of having your patient being really accepting enough of themselves and understanding that the tics are not like a personal flaw. It's not that there's something wrong with them. Is so important, and it goes such a long way if they're then able to talk about the tics to other people as if it's just something like having brown hair or like getting the hiccups. Right? Like there's no personal devaluation that comes with it. And so getting the kids to be able to talk to others about it can really go a long way with managing peer issues and perceptions. So with younger kids, of course, getting parents involved, trying to promote play dates and all these other things. For older kids, getting them to create like a social map with you, for example, to identify peers that they feel like they can talk to and ones to avoid can be really helpful as well. Planning out different conversations, how you would talk to others, and then assigning homework. Again, this is with the older kids. Managing bullying. So there is a treatment manual that looks at bullying. It's the Peers Treatment Manual. The assumption behind this approach is that bullies tease others to elicit a strong reaction from them, which makes them feel in control and attracts attention from bystanders. So the strategy in this approach is to tease the tease. So for example, if the bully says, "What's wrong with your face?" The child could respond, "I've got tics, so what?" Okay, so this works because it limits the attention-seeking function of teasing, and the bully gets bored and moves on. If anyone's heard of Brooks Gibbs, he has a fun YouTube video that kind of demonstrates how you can also win against a bully. The assumption here is that the bullies tease others to gain dominance or power over others. Strategy would be don't show the bully any anger, negative response, and instead behave as though you don't care, letting the words sort of bounce off. Highly recommend watching that video because it'd be very helpful. Lastly, troubleshooting peer relationship issues. So some schools, I've had kids where just some schools are just, they're just not great for the kid. And in these situations, these kids might not necessarily be able to leave schools. And so I think at some point, it's okay to know that school is not going to necessarily be the place for every single kid to get their positive peer social interactions. So outsourcing elsewhere, finding alternatives where they can get that positive environment and build relationships is so important. So they have something, right? Something is better than nothing. All or something, really. Also too, social skills. So some of these kids really do struggle with social skills. So looking at training can be really helpful. So I'm sorry we started a little bit late, and so I had to rush through the last little bit. I hope I can have some time to answer questions, Julian.